cell after head and neck, right? It's really not true, is it? We have two important topics today. One is a chronic disease, which is treated with a simple amino acid, revolutionizing neurochemistry and neuropharmacology. And the second is a little series of vignettes on drug-drug interactions. And we can do whichever you wish first. We'll do the disease first. And Parkinson's disease is the example. Levodopa is the drug. And miracles are the byproduct. Truly, without any question, this molecule has made the life of the Parkinsonian patient inestimably better. Just no question about what this simple drug has done. It's kind of fun to go back and look at how this drug evolved, how we can improve our patients with it, look at the shortcomings of the molecule and its treatment, and then also think about ways we can look at other neurologic diseases in the very near future. I was going to have a patient with Parkinson's disease here today for you. Unfortunately, he called because of the weather and was afraid to come because of the report that was going to start icing. And that's typical for a Parkinsonian patient, as a matter of fact. One is that it's a disease of locomotion, and therefore if the surface upon which locomotion is going to be done is not ideal, they don't want to have anything to do with it. Secondly, they'll use any excuse to avoid facing a group like you. That is, they simply don't like crowds and people because the very presence of people makes them, exaggerates many of their symptoms. And therefore, commonly, the Parkinsonian patient is almost not known to exist by many people because they secrete themselves away in the depths of their home and rarely are seen in many circumstances. And levodopa's changed much of that, but not all of it. Well, the disease. It has four major features. Coincidentally, the notes on both these topics are very well covered, and that is both lectures today. The disease, and I'll follow the notes fairly closely. The disease has four major components. The most important one is tremor, shaking, and the name shaking palsy has been given to these individuals. And of course, all that shakes is not Parkinson's disease, and we'll note that it's important for you to differentiate that. So they have a very specific tremor. Classically, it's called a pill rolling tremor, and it is as if there were to have between their thumb and first two fingers a pill, and they would roll it such as this. And this is the way it might begin. And then, of course, it would get more coarse, might involve more extremities, and become an incapacitating problem. So you have a rapidity of movement, number one. Two, more important to the patient, although it's less cosmetically, less tremor is the component which is unacceptable to the patient, but it's not incapacitating. Rigidity is the feature which is incapacitating, but it's not recognized by the unknown eye. That is, the person who's not sophisticated will not pick that up so readily. Anyone can see the tremor. Take a cup and a cup and saucer, it'll rattle. Okay. Now the rigidity is both to passive movement by the examiner and for the patient himself. And every movement that individual takes, every movement of the involved extremity, and it can involve, of course, the entire body, will require him to expend more energy. And in your examination, if you take that arm and try to move it, you'll find that you have to expend more energy in moving it. Therefore, Rigidity is important, and it's important in your diagnostic criteria, and it contributes to a secondary phenomenon, which is fatigue. These people are just tired, very tired at the end of the day, mainly because they've expended much energy. Another feature is called bradykinesia, and as the word suggests, it is slow movement, and it's intriguing, of course, that in the presence of a flapping tremor, you'll have also a slow movement on a volitional sense, and that's a problem for the patient. And then the fourth major feature is posture defect, and invariably these individuals will tend to have a slowly flexing kind of posture, so that if they're not careful, they suddenly approach such a position as this, or more so. And therefore, you can see how difficult it is for them to emulate with the four features I just mentioned. Now, minor phenomena include a mask-like facies. That is, if you look at them, they seem to be expressionless, like the faces of some people early in the morning. That is, you look at them and you don't know what they're feeling or what they're thinking. Now, this occurs even when they're happy, even when they're in a good mood. Consequently, we physicians who look at these individuals don't recognize the Parkinson's disease, will immediately assume that they are emotionally depressed. After all, we all must go around with a smile on our face. And consequently, many patients who have this disorder are treated with antidepressants by their physician because they don't look as if they're happy. And you know that that's inappropriate. Other features include seborrhea, and a very funny, and if you put this all together, they'll have a characteristic handwriting wherein they'll begin the first letter of their name in a full-size letter. And then by the time they end their letter, that word or sentence, the letters are getting smaller and squinched up together, and the last letter is barely perceptible in size. So they truncate their sentence. And of course, there'll be tremor in the pen scratching. Now, these are the features of Parkinson's disease, and there are others which are noted in your book. They are not emotionally depressed by and large. The families can make them so. They don't seem to be, they aren't unhappy commonly. They are unable, though, to articulate words properly and rapidly. Therefore, it's not uncommon for a student or a friend to ask a patient with Parkinson's disease, "How are you today?" His mind is not dulled, and he immediately knows the answer, good, bad, or indifferent. But his bradykinesia of his muscles in his face do not allow him to articulate the word good, bad, or indifferent. Consequently, the nervous individual who's approaching this patient will say, "Gee, doggone, he didn't answer my question. I gotta give him another one. Right? I gotta say something else. So ask another question." So now the man has two answers in his mind, and he can't articulate either. And then this becomes a very frustrating circumstance for all concerned, especially the young physician, who will then ask a third question and the fourth question to complicate the issue further. And the guy will say, "The hell with it all," and he won't answer any question. And you say, he's depressed, give him something. Okay? So that's a feature which you have to be very careful of. Well, that's an idea of what the disease is like. And in the older days, lifespan was 5, 6, 8 years. They were bedfast, and second to bedfastness would have a variety of infections and so forth. Okay? Now, their lifespan is not impacted at all by the disease. The disease merely makes their life more complicated because of drugs we're going to give them. The theoretical basis now for the treatment is really elegant, and I'll go through it with you. And of course, the lesson here is that meticulous observation and meticulous analytical technology will help us understand diseases. And the importance of this is that if indeed we can improve Parkinson's disease by giving a simple amino acid to the brain, just imagine what we might be able to do with schizophrenia or other neurological diseases or other diseases which are not associated with the nervous system. If we understand the metabolic basis of disease, we can improve patients dramatically. That's why people who are investigating disease have no empathy for the sloppy kind of approach to therapeutics which exists in some areas of our community. Now, it was recognized in 1959 by a man by the name of Ole Kornikawicz. And this genius of a man, beautiful person, remarkable individual, noted that several features of importance. One, if patients were given serpine or phenothiazine, some of them would develop Parkinsonism. Okay? Now, he knew that serpine depletes catecholamines and dopamine from the neural tissue, and hence implicated catecholamines in this fashion. Secondly, he did some assessment of brain tissue and recognized the fact that the substancia nigra in the basal ganglia of these individuals, instead of being substantia black, was substantia wishy-washy gray. The melanin was gone. Now you know from your chemistry and from your reading of your notes that melanin, neuromelanin, is a quinoid formation from catecholamine. It's a condensation product of many catecholamine molecules giving this black pigment, correct? So he did one more experiment which is really unique. He analyzed these tissues also for content of neurotransmitters and found that the neurotransmitter dopamine was low in concentration. Very important. He did the following tests. He said, I will make the substantia nigra black by giving melanin-stimulating hormone. Now, I'll do this for the patients. He gave some melanin-stimulating hormone to patients and made their skin darker and made their Parkinson's disease worse. Wrong trail to follow. He then said, I will try to replete the depleted store of dopamine in their brain, and therefore I will administer dopamine intravenously. As you know, dopamine intravenously does not pass the piloglial or the brain-blood barrier. Consequently, no response in the brain, lots of responses in the kidney and heart. Wrong trail again. He said, let me then give the metabolic precursor to dopamine, which is levodopa. Levodopa is a simple amino acid which is the precursor to dopamine by decarboxylation. You recall that? Dopa is dihydroxyphenylalanine. Remove the carboxyl group by enzyme L-aromatic amino acids decarboxylase, and you end up with dopamine. He said, since dopamine doesn't pass the brain, I will give the precursor of the amino acid which will pass into the brain. And he did this study very carefully, and this astute, fine man observed that the patients given this drug were improved slightly. But this gentle man gave small doses of the drug because he was afraid of giving larger doses because, as you know, levodopa is metabolized to dopamine, and dopamine goes to norepi and then epi, and he was giving grams of dopa, hundreds of grams of dopa, hundreds of milligrams of dopa, several grams, okay? And he was afraid that most of these molecules and would end up with norepinephrine and epinephrine and cause all kinds of trouble, and dopamine too. So he was very cautious and gave small doses, milligram doses, to replete microgram deficiencies in the brain, and did very well. He published this literature, and of course other people tried to duplicate the experiment and could not do it. And he became depressed too because of that. No. And it required a very rough and tough and gruff man by the name of Dr. Kostious, Georgy Kostious, who was not as good a pharmacologist and was not so fearful, who gave larger and larger doses of dopa and found that unequivocally the patients were improved. So that's the background. A very exciting and very important study. Very important. Now the levodopa itself is the important drug. It is efficient in about 75% of patients. And what I would like to do now is tell you why it's efficient in 75%, and then tell you why it doesn't work in some 25%, okay? And how it's efficient in 75%. Okay. Factor number one is that it is, what should I say next? The efficiency of the molecule is based upon a very important factor. You give the drug by mouth, and there's an enzyme, L-aromatic amino acids decarboxylase, and this enzyme is ubiquitous in the body. L-aromatic amino acids decarboxylase, and it's everywhere. Okay? And so if you give 100 molecules of dopa, it appears that 99 of them are lost by the enzyme action, and only one molecule passes the peel-glial barrier and enters the brain. Therefore, the vast amount of dopa that we use, grams of dopa, are metabolized extracerebrally, and only a small number of them reach the brain to replete the depleted stores of dopamine. Clear? Now, where are these enzymes? They are in the gut. So when you put a tablet of dopa in the stomach, the enzymes which line the stomach will break down dopa to dopamine, and therefore it's inaccessible. When it gets into the bloodstream, this enzyme is in the bloodstream. When it passes through the liver, more molecules are broken down. The peel-glial barrier itself is replete with the enzyme L-aromatic amino acids decarboxylase, and will keep this molecule out. So that's factor number one, that there is a tendency of the body to protect neural tissue by preventing these precursors to amines to appear in it. Consequently, the result of this is that when you give a dose of drug which has a half-life itself of perhaps 2 hours, the blood level which is achieved is sawtooth pattern-like. You give a drug here, and in 1 hour you have a peak blood level, and 2 hours you have a low level again. So there will be Parkinsonoid here, they'll be fantastically cured here, they'll be toxic here, they'll be fantastically cured here, and under-medicated here, all within 2 hours in some individuals. And therefore, they must in fact put their day, mold their day around their kinetic curve or their dopa, you see? And that's a very serious problem. It's overcome by giving an inhibitor to dopa-decarboxylase, and we'll talk about that in a few moments. So one of the problems with dopa is that it's a short half-life, rapidly metabolized, and there are peaks and valleys in their day. Now, this peak, the valley, for the troublesome point may come literally in an instant or two. And a classic example is the patient is trying to come to your office, which of course is the penthouse suite of a beautiful building in town. And he must take the elevator to get there, correct? And he'll press the button for the elevator, and then he hears, "Ping." Doors open, and he's frozen into immobility and can't get in the door while the door is open. And he's trying to move and can't get there, and then he starts to take the step, and the door is closed before him. This is the kind of trouble they commonly have. And this kind of deficit can occur in here very quickly, even though they may have marched up to the elevator door in rather good shape. Now, another trouble with dopa are its side effects. Side effects. And these are listed. Let me just go through a couple of them with you. The side effects are important, and you should know them. One, all dopamine compounds cause nausea and vomiting. The physician or researcher who finds a dopamine molecule which is not emetic, will be doing medicine a great service. Apomorphine is dopaminergic. If you look at the apomorphine molecule, you'll find dopamine in it. If you look at other important emetic drugs, you'll see dopamine in it. So nausea, vomiting are common side effects of levodopa. You avoid these by increasing the dosage very, very slowly. That is, the first day you see the patient give a minuscule dose, and then a week later you'll be up to a larger dose, and so forth. Now, there is a psychological component to this, and if your patient starts vomiting or vomits frequently when he's with the medication, every time he sees the pill, he becomes queasy. So there's a psychological component. But believe me, it is not only psychological. I have a patient, a very lovely lady, who, because of her tremor, occasionally will drop a dopa pill on the floor, and her little puppy dog loves to eat these things, and eats them and vomits on a Persian rug every damn time. And the dog, there's no way for the dog to have, that I recognize, any understanding about that. So there's no question it will cause vomiting and nausea. There's no question that the compound will give you cardiac dysrhythmias. And you can understand that from the metabolism of the molecule. Levodopa goes to dopamine, which has cardiac effects. But more importantly, dopamine goes to norepinephrine and epinephrine, which unequivocally have cardiac effects. And so cardiac dysrhythmias are important side effects. If you read the package insert will say, "Hey man, don't use this stuff in old people because it'll cause cardiac trouble. Don't you dare use it to anyone who has a hint of cardiac disease," and yet Parkinson's disease occurs in only old people, and every damn one of them has cardiac disease. What does that mean to you? That means you have taken the responsibility to give this molecule to the patient, and you must share this information with him. Our drug firms have nicely shifted responsibility onto you. Okay? So you must discuss the side effect. I've had a patient who was vacationing in Hawaii and who had who was on levodopa and had angina called me. These people have tremendous closeness to their physician. And we brought him home, okay, this was in Texas, brought him home to Texas, and he was on dopa, because if he didn't have dopa, he would be so stiff he couldn't move. So he's on dopa while he's having a heart attack or angina, and he was operated on with a coronary bypass while on dopa. If you read the package insert, it says, hey boy, don't you do that. Okay? So you've got to share this information with your patient, between you and the patient. If you give this molecule to patients and don't tell them that, and they have myocardial infarction, you may be responsible for that. So cardiac diseases are important. The hypotension may occur as well, mechanism unknown. Another side effect which is important are the extrapyramidal movements. And this is very exciting. This is very exciting because we don't know why this occurs, but they occur nonetheless. And what really happens, you take this patient who is stiff, can hardly move, and is shaky, okay, can hardly move, and you give him dopa, and you make him supple and loose as a goose, and he develops as a side effect these extrapyramidal funny movements like this. Sort of funny movements, and all kinds of tick-like movements may occur. Now, it's interesting at that point that he is no longer stiff. As a matter of fact, he looks like a Huntington chorea patient. He might be doing this kind of thing. And that patient at that time is very happy with himself. He'd rather have a Huntington chorea-like picture than the stiffness he had before. But mama and dad and son and daughter can't stand to be in a room with him. This guy is up and around. He's in the chair, up and up, this kind of thing. And it's very difficult to be in the room with him. But he is happier. Now, this is interesting, and it's also interesting in that you have changed one disease, which is dopamine deficiency, into another by giving dopamine excess. And of course, this excites everyone, saying, hey, Huntington chorea may be dopamine excess. As a matter of fact, you can take patients who have the heritable disorder, which is dominant Huntington chorea, and you can take these little children who are going to have Huntington chorea, give them a dose of dopa, and prove it. Would you do that? Would you do that? Would you? You can't do that. The little junior is happy and jumping around. He doesn't have a complaint. You can't prove to him he's going to have Huntington chorea if you have no alternate, if you have no way to treat that. Of course, this is some information that we have, and as we said before, a patient has no more right to all the information the doctor has in his mind than he has to all the drugs he has in his bag. You have to keep this back, in my opinion. I don't think you might share it with the parents, but you certainly can't have a child who's 8 years old knowing that he's going to have Huntington chorea. Somehow I think a child couldn't tolerate that information. But again, shows you how these diseases are interplaying one with the other, and the impact of these molecules on neural tissue, and the hope that so many of us have that this decade is the decade of understanding the mind and better treatment of it. So that's another important side effect, the extrapyramidal movement disorder, which is so you'll need to titrate your patient between stiffness and Huntington chorea to make him happy and the family happy as well. Of course, if you give dopa to a patient with Huntington chorea, it makes it much worse, needless to say. Now, other CNS effects include hallucinations and nightmares. Now, these are fascinating. Again, why a simple amino acid given to a patient can cause hallucinations and nightmares. They absolutely will see a dog in the corner, or will see a bug crawling along the bed sheet, or will see someone who they know but yet has been dead for 10 years and will have a conversation with them. These hallucinations are among the most vivid known outside of the major hallucinogens we're going to hear about next week. Their visions, which are not real, are so vivid, it's unbelievable. Had a patient who had this disease, treated with dopa in a hospital, did very well. When he went home, he found someone had moved into his house. He's a very fine southern Kentucky lumberman, wealthy man, beautiful big home, I understand. And when he got there, this very fine man saw this visitor in the house. And since he's such a fine southern person, he didn't think of saying, what are you doing here? He developed a nodding acquaintanceship with his vision. No question about it. How you doing? Good to see you. And they'd walk back and forth. He said, that's kind of strange. I don't know who the hell he is, what he's doing here. But he extended perfect southern hospitality. He could describe this man later on to the very fact that he had an old lye burn on his face, that he was the age, the color of his eyes. In other words, vivid impression. Vivid. One day, I became aware of it because of the following scenario. The man, this patient, walks into his parlor or sitting room, and there on a couch is his wife and this vision sitting there on the chair doing something together. And he got all nervous because she was knitting and he was holding the yarn. Can you imagine that? A real vision and a guy next door. So the string or the cord must have gone between the vision and the real person. He said, what are you doing knitting with my wife? And the wife says, who have I needed knitting? They called me. We lowered the dose by a half a gram a day, and the vision moved out and didn't return. True story. True story. True story. And there isn't a neurologist in town who doesn't have better stories than that. Now, it excites us all because why does a simple amino acid like levodopa cause this vision disturbance? And all we're doing is giving levodopa okay? Just giving that stuff. Simple dihydroxyphenylalanine, simple stuff, and yet the guy goes crazy. Well, one of the theories is that we methylate this compound here, and you form the 3-O-methyl-dopa derivative. And if you look in the hallucinogens, which Dr. Morgan will tell you about next week, the 3-O-methyl phenyl molecule is common among them all. And many hallucinogens have that kind of ring with methylation there in the 3-O position, and maybe that's the thing. Maybe that's the thing. Very exciting. Now, dopa is in high concentration in neural tissue. We used to get it from fish brain, and this might explain some of the visions that the ancients had of a religious nature. Those religious people who might eat a lot of fish or fish brain could hallucinate on them because of the dopa they have, and they might see all kinds of visions. Very exciting to think about that. Or the berserks, we told you about, may have been having 3-O-methyl processes going on in their brain, and hence they had the vision of hurting people, etc. The need to hurt. The last side effect is probably not a side effect. I've never heard of a patient complain of increased sexual appetite. So I don't know if you call it a side effect or not. However, the mate commonly complains that old dad is a little not quite like he used to be. He used to be quiet and not bothering anyone, but now he's a little more aggressive than mama can take, and problems occur because of that. Now, it's interesting that when this first occurred, we all thought it might have been just because dad was being awakened, that he was no longer stiff and rigid, totally body, and sitting in a chair. Very poor choice of words. I'm sorry about that. I'm really sorry about that. I didn't mean that at all. And he would be... Okay. Okay. So he would not be physically able to participate in sexual activity, physically and emotionally. However, it's clear that levodopa actually causes the release from the hypothalamic areas of, and as a matter of fact, most hypothalamic areas are dopaminergic in nature, and consequently, luteinizing hormone, growth-stimulating hormone, FSH are increased in men who take this compound, and this may give increased sexual drive. Further, women who take this, who've been menopausal for some length of time, may menstruate. The vaginal secretions will change to a more luxuriant premenopausal nature. So there is a youthful nature. There's a youth-producing component to the patient with Parkinsonism. As a matter of fact, if you look at them very carefully, you notice that they commonly look much younger than their stated age. So those are the important side effects of that molecule. Now there are important drug-drug interactions which you must know, and there are beautiful examples. And as you use more and more powerful medications, they interact more and more. And levodopa is no exception. Now, it's important for you to understand that in the older days, when a patient would have nausea and vomiting, he would be treated by vitamin B6. Ladies who were pregnant and had hyperemesis gravidarum, they would just be vomiting every morning. The old doc used to give them B6. And then when these same old docs, and it worked very well, when their patient with Parkinson's disease would develop nausea and vomiting, they would give vitamin B6. And you know what happened? It made them better. They didn't vomit anymore. You know what happened to their Parkinson's disease? It got worse. You know why? B6 is a cofactor for the enzyme dopa-decarboxylase. So what happens is that B6 given to a patient will enhance the extracerebral metabolism of dopa. Consequently, the dopa you give will have even less than one molecule available for entry into the brain because the enzyme machinery is enhanced extracerebrally. Everyone understand that? Okay. Important side effect. Others include giving an MAO inhibitor to a patient on dopa and losing his life. Now, that's not a side effect, that's tragedy. Again, remember I warned you that these people look depressed. They look depressed. Even though they're taking dopa, they still look emotionally depressed. They have a mask-like facies, don't smile commonly. If they smile, it may be short-lived, and they don't look happy. And this is the setting wherein a minor tricyclic antidepressant would be given, and it won't change them because they're not depressed. They say, well, I got to make this guy happy, so they might reach for, and occasionally, each year I'll hear of it, they'll reach for the MAO inhibitor, Parnate or something, okay? They'll give this compound, and catastrophic events occur within minutes of administration of the drug. The MAO inhibitor inhibits the metabolism of all of the monoamines which evolve from dopa. Dopa goes to dopamine, and dopamine is not broken down to norepinephrine. Norepinephrine is not broken down to epinephrine, and these amines hang around in the body and cause all kinds of trouble, such as hyperpyrexia. The body temperature goes to 107, 108 in an hour. The blood pressure goes to 300 over 200 in an hour. Heart rate goes very, very high. They become very anxious, and they die. Another side effect, which is less dramatic, but probably more common, is the interaction between dopa and reserpine. Patient's pressure is a bit up. Reserpine is given, and it interferes with the action of dopa. Phenothiazines are given for the treatment of the nausea and vomiting. Phenothiazines will stop anyone from vomiting. Okay. So if a person is vomiting, give him phenothiazine. It stops the vomiting, but it stops the effect of dopa as well. So the side effects which occur from drug-drug interaction are myriad. Remember I said that dopa-decarboxylase is a very important enzyme in the body, and it tears down dopa significantly. Therefore, we could use an enzyme which would break down, which would inhibit the enzyme. Let me start again. We can use a drug which will inhibit dopa-decarboxylase and in that way prolong the action of dopa. Follow? And what would that drug be? You know one of them. You could use alpha-methyl-dopa. Alpha-methyl-dopa, the antihypertensive medication which you all know about now, could be used in this setting to inhibit the degradation of dopa. Correct? But there's a better dopa-decarboxylase drug, and that is Alpha-methyl-dopa-hydrazine. And this stuff is really great for inhibiting dopa-decarboxylase. And this stuff will prolong the action of dopa several-fold. This stuff will change the half-life of dopa from 2.5 hours to 12 hours. This stuff will take the sawtooth pattern of the yo-yoing effect out of a patient's life significantly in many instances. Therefore, with this material, instead of having a blood level curve which goes up and down every 2 or 3 hours, we'll have it go up and stay around for a longer period of time. This material will decrease the need for dopa, 50 to 80%. Don't give, well, let me go back first. It is now possible in a fixed dose ratio to give dopa and the inhibitor at the same time, and this preparation is called Sinemet, and it's manufactured by the Merck Sharp and Dohme Company. It's really fine stuff, but you can't give Sinemet with dopa, because the inhibitor in Sinemet would also inhibit the metabolism of other dopa. You follow? Clear? Okay. Maybe I better say, is it clear more often? I'm afraid I don't do that.